Good morning or afternoon, folks. Welcome everyone to the August 3rd, 2020 COVID-19 care rounds focused on EMS patient care and operations. I'm John Kramer. I'm an emergency and EMS physician. I'm the director of the National Office of EMS, the National Highway Traffic Safety Administration. And I'm also the team lead for the HHS Healthcare Resiliency Working Group, EMS pre-hospital team. I'm also the EMS Medical Director for the Caroline County, Maryland Department of Emergency Services. The purpose of these sessions is peer-to-peer, real-time sharing of COVID-19 EMS challenges and successes. In developing these sessions, our guiding principle is, if I'm preparing my EMS system for COVID-19 patients, the clinicians I want to learn from are those who have the most experience. This is a voluntary public-private collaboration, and thanks to the multiple professional organizations who have collaborated in this series. It is not intended to be redundant or replace any organization's initiatives. It is intended to be sharing of clinical experience, not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on healthcare providers sharing their successes and challenges with other healthcare providers. Thanks to Project ECHO, Dr. Bruce Strominger, Amanda Dizon, and Amy Armistead, and their team for the peer-to-peer learning platform that we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Tuesday focusing on critical care rounds, and Thursday on emergency department rounds. It's self-evident that our nation's medical response challenges are changing every day. We'll continue to work to identify topics for these peer-to-peer rounds that are most timely and helpful to clinicians. For the ECHO clinical rounds, we continue to have participants from all states and multiple countries, predominantly EMS clinicians, physicians, and nurses. Special appreciation goes to NETEC, the National Emerging Special Pathogens Training and Education Center, for their support with the rounds. These ECHO clinical rounds and NETEC's webinars are complementary to each other. We continue to receive many questions for each of these rounds and apologize in advance that we're not able to answer all of them. We have selected major themes from the questions received and hope to cover some of those. We'll also be doing crowdsourcing and polling questions with results shown in real time, so we all have the opportunity to learn together during these sessions. I'd now like to turn it over to Dr. Bruce Strominger to review some of the logistics and other information for the session. Bruce?
Thank you, John, and welcome to today's guest presenters and our panelists and to all the participants joining today. Just a few housekeeping items. Hopefully everyone sees the Q&A button along the bottom of the Zoom toolbar. We really want your questions and comments regarding today's presentations. Please put them in that Q&A space. We'll be tracking that and try to get to as many of them as we can. In the chat button, chat space, if you've got technical or logistic issues, that's a good place to put those. When John asked the crowdsourcing question, we'd really appreciate you putting your responses in the chat, and we'll look there for those. Today's session is being recorded and your attendance is consent to be recorded. Thank you for that. The presentations for today will be made available afterwards through a follow-up email coming from Project ECHO. They will also be on our website, and we'll share a link to the website so you can access prior presentations from other sessions as well as today's. And the recording link will also be available through our website in the next couple of days. There will be CME and continuing professional development credits available through the University of New Mexico, where Project ECHO is based. We will put a link to the survey in the chat about 15 minutes before the end of today's session. There should also be a link in the email announcement that went out earlier this morning. Just a reminder that these sessions are learning sessions focused on improving patient care and health systems and supporting clinicians. We want to keep them apolitical, and we really thank you for supporting that. Just want to share how we use your data when you register, the polling question data, the chat, etc. We keep that data confidential. It's all de-identified. It is shared with HHS ASPR so that they can inform the national COVID-19 response. And just want to make sure everyone's aware of that. So thank you for sharing your responses with us. Now I just want to hand it over to Sharon Van Arsdale to give us an update on the NEATech webinar series. Sharon.
Thank you so much, Bruce. Hello, everybody. Happy Monday. My name is Sharon Van Arsdale. I'm the Program Director for Emory Serious Communicable Diseases Unit. By background, I'm an emergency department nurse, and I'm also the Director of Education and Resources at the National Emerging Special Pathogens Training and Education Center. It's been an honor and a privilege to be able to be part of these clinical rounds, to be able to partner with Project ECHO.
I think Sharon may have dropped off there, so maybe I'll just pick up for her. NEATech has put together a series of webinars on issues, many of which they have noted through these clinical rounds as being hot topics. And this week, they're going to be doing a session on supply management and inventory control. And part one will be this Wednesday. Part two will be on Friday. And would really encourage you all to take advantage of those learning opportunities. Also, the AAMC is a partner in the clinical rounds, and we just want to call attention to their clinical guidance repository. The AAMC keeps this updated on a weekly basis, and it's a rich source of clinical guidance related to COVID-19. Also, quick announcement on a related series of HHS telemedicine learning sessions. It's a 10-session series. The third session will be this Wednesday, and we will put a link in the chat. It's targeted to primary care clinicians who are trying to improve their ability to implement telemedicine or to start using telemedicine. So we encourage all interested to join those. And with that, John, I'm going to hand the mic back to you.
Thank you, Bruce. And thank you, Sharon and Bruce, for helping to fill in. We appreciate it. We are, I'm sorry here, I lost the view here. Thanks, Bruce. I just wanted to make sure the crowd sharing or crowdsourcing question was up. So for our crowdsourcing question today, folks, please, thinking about your agency's current status in the COVID response, what is the biggest education-related issue that you and your agency are facing today? And when you respond, please indicate the country you're responding from or the area of the United States, just so we can help put that in perspective. As folks, or as we just alluded to with that crowdsourcing question, our focus in today's discussion will be on the impact of COVID-19 on the EMS education community in general. We've got two excellent speakers that will be joining us in just a second. We also have a number of other folks from the EMS community who have been able to join us as part of the panel today to help with our panel discussion. So before we get into the specific questions, I'll ask the panelists to unmute yourself, and we'll go through just very quick introductions so that folks in the audience know who we have on the panel today. Carol, we'll start with you, please.
Good morning. I'm Carol Cunningham, State Medical Director for the Ohio Department of Public Safety, Division of EMS.
Thanks, Carol. Dan?
Dan Gerard. I'm the president-elect for the International Association of EMS Chiefs.
Great, thank you. Jay, welcome.
Good morning. I'm Jay Scott, Executive Director at CAPSI.
Thank you, Jay. April, welcome back.
Hi, I'm April Heinze. I am the 911 and PSAP Operations Director for NENA, the 911 Association.
Thank you. Alex?
Hi all, I'm Alex Isaacov. I'm an emergency medicine and EMS physician at Emory University and the EMS lead for NETEC.
Thanks, Alex. Garth, good morning.
Hi all, my name is Garth Gamer. I'm Medical Director for Phoenix Fire, Glendale Fire, and Surprise Fire Medical here in lovely Maricopa County, Arizona.
Thank you. Good afternoon, Rob.
Hi, everyone. I'm Rob McClintock. I'm the Deputy Director for Fire and EMS Operations with the International Association of Firefighters.
Thank you. Bill and Kathy, we'll circle back to you in just a second. Good. Yeah, Gerson.
I'm David Gerstner with Dayton Fire Department, and I'm the Regional MMRS Coordinator in West Central Ohio.
Thanks, Dave. Rick?
Yeah, I'm Rick Hunt. I'm a Senior Medical Advisor for the National Healthcare Preparedness Programs at HHS ASPR.
Thanks, Rick. Afternoon, Paul.
Afternoon, Paul Bittinger. I'm an emergency physician and director of the Center for Disaster Medicine at Mass General Hospital.
Thank you. George, thanks for joining us.
Hi, good morning. George Hatch. I'm the Executive Director for the Committee on Accreditation for the EMS Professions.
Thank you. Craig?
Craig Manifold, EMS physician in San Antonio, Texas.
Wonderful. Thank you, Craig. And Sharon, even though we have your stock photo, nice to have you back online. Thank you.
Thank you.
It is now my pleasure to introduce Bill Seifert. Bill is the Executive Director for the National Registry of EMTs, the nation's EMS certification organization. Bill has over 2 decades of leadership experience at federal and state EMS agencies, as well as experience with a nonprofit certification organization. He is a nationally registered paramedic and has a Master of Science degree in Emergency Health Services, Administration, Planning, and Policy from the University of Maryland, Baltimore County. Bill, thank you for joining us.
Thank you for having me, John and everyone. I'm certainly glad to be here to provide an update in terms of the, I guess, the systemic effects or impacts that COVID has had, certainly on the National Registry, but more importantly, more broadly on our EMS community, specifically our EMS educational systems across the country. So what I want to do is I want to start with a little bit of a historical overview to provide some context in terms of the impacts that COVID has on EMS. And I want to start by saying that prior to COVID, there was a lot of discussion on the perceived EMS provider or professional shortage. And this workforce shortage was highlighted. I just literally took snips of multiple articles that I was able to acquire. But this was the primary focus of a lot of conversation across our country as we were preparing to emerge into or go into and encounter COVID. So this shortage was, whether it be real or perceived, was truly able to be demonstrated time and again across multiple systems. And this is what we were dealing with, at least from a systems perspective and an educational perspective and operational. So we went into COVID with in the midst of a perceived shortage. COVID happens, and from a testing perspective, this gives some context in terms of the significant impact that it had on us. These are charts that we use on our dashboard at the National Registry. Look at the number of providers who are tested and subsequently certified, And we have 3 years here, 2018, which is in green, 2019 in blue, and then 2020 in red. And you can see when COVID hit, our numbers dropped significantly and continued to be that up until about the second week in July, where we were able to increase capacity, increase the number of students being tested. So the impact that it had on the National Registry of EMTs as a national certification organization certainly was significant, but more importantly, the systemic effects that it had across the country are huge. And so these people, these several thousand candidates that we're not testing every week, that's several thousand candidates that are not being eligible for state licensure and subsequently eligible to be used for the EMS workforce going forward. So the impact from COVID for several months was fairly significant. And we looked at that certainly at an immediate perspective and at a long-term perspective as well. The immediate effect was obviously the number of EMS professionals that could enter the workforce after they got nationally certified and then licensed at the state and credentialed locally dropped immediately. We also saw an immediate shutdown of education programs. That was largely due in part to states shutting down colleges, universities, but also with EMS, as you know, the need for obtaining clinical and field internship experiences stopped because of the risk of exposure to COVID. So there were some significant immediate effects, which we were able to work certainly with our partners and certainly through efforts led by NHTSA and all of those in the EMS circles were able to come together to come up with some alternatives and short-term workarounds with that. But we have in front of us some long-term effects that I feel that we will be potentially wrestling with for upwards of a year once we're able to get back to a traditional administration of classroom as well as clinical experiences. Unless we're able to come up with some potential alternatives and assurances that we're able to appropriately educate the candidates and then prepare them for entry-level practice, our certification exam, the licensure exam, we are going to have some long-term effects from this. And those effects, like I said, I don't think we will feel for several months from now, given the fact that the backlog of students that were temporarily shut down and are now resuming some of the educational experiences may not be able to test for a later period. So there will be a potential shortage of providers 6, 9, 12 months from now that we don't realize today. So those are long-term effects and impacts from COVID. With respect to National Registry as a nation certification organization, we were able to take some pretty quick action, and our board was able to, I think, act without question proactively and based on the needs of the community we're serving in these unprecedented and absolutely never seen before times that we're experiencing, especially back in March and April. In early March, our board, we started communicating with the EMS community, and on the 13th, our board extended the recertification of providers who were due to expire on March 31st till June 30th. On the 16th of March, we had a pretty much an unannounced shutdown of the entire testing network for Pearson VUE, which put us in a very difficult situation where we were unable to test candidates who were otherwise eligible to sit for the examination and had completed the education program. Within a week, we had testing centers open back up. There was access that was granted to testing centers for essential personnel. We were able to get EMTs and nurses recognized, certainly with Pearson and others, as essential, and they opened up their testing network just for us. And we were able to resume testing within the span of about within the span of a few days, under 5 days. The board also implemented a provisional certification during that same time period. That is for those individuals who have completed the cognitive examination successfully, the written exam, but are unable to do the skills or psychomotor examination. So there was a provisional certification that was implemented, and some alternatives for administering the psychomotor examination with appropriate social distancing was implemented later in the month of March. And finally, in April, we were able to initiate online proctoring for our written examination to address the capacity issues associated with the appropriate social distancing that has to take place in Pearson VUE testing centers. And right now, we're about 35 to 40% of our EMT examinations are being administered via online proctoring, closer to 30, 35 actually right now. So we're able to meet those demands. And as you saw on the chart earlier, our number of candidates we're able to test to prepare for licensure and then ultimately enter the workforce is slowly on the uprise. So there are certainly a lot of lessons learned during this, positive lessons that we take away from it. But the important takeaway, though, that I'll end with is the effects of COVID have impacted the entire system of EMS, EMS education in particular. And certainly we're happy to be a part of that and help to be part of the solution and look forward to continue partnering with those in EMS, specifically those involved with EMS education. So I don't know if, John, you wanted to have me take any questions now, or we can come back to questions after Kathy's presentation.
I'll ask any of the panelists, do you have any burning questions for Bill right now before we move on to other issues, and then we'll be looking at other aspects of the education program? All right, thanks, Bill. We'll circle back and stand by. It's now my pleasure to introduce Kathy Robinson, Program Manager with the National Association of State EMS Officials. Kathy is the staff resource for EMS education and specialty care at NASEMSO, and emergency nurse and former paramedic. Kathy coordinated nationwide implementation of the EMS education agenda and served as the program manager for the most recent version of the National EMS Scope of Practice Model Update. She's a recipient of multiple national honors and awards from both nursing and EMS communities, holds a bachelor's in nursing management from Penn State. Kathy.
Thank you very much, Dr. Kramer. I'm pleased to join such a distinguished panel today. The folks that you've seen on the screen are friends and colleagues that we work with pretty much on a daily basis. So it is really an honor to be here. And I'm actually going to take a little step back about from the specific COVID things, because Bill did a fabulous job of outlining the challenges that we're facing in regards to certification. But I wanted to talk a little bit about the questions that we're getting at the national headquarters of the National Association of State EMS Officials about what EMS personnel can and cannot do with regards to a COVID-19 response. Next slide. I provided these slides actually in a generic format because I know that the resources that folks access are helpful to them later. So you'll see that these would be adapted into any of the presentations that you might wish to do about scope of practice in the future. As far as the education agenda is concerned, it is tied with the national, we work closely with the National Association of EMS Educators to make sure that the scope of practice model serves as a reasonable guide to educators for EMS education moving forward. And it is obviously the basis of the conversation today and the platform for everything that we do in EMS regarding patient care. Next slide. Bill has already talked a little bit about the certification process and how states use that to make sure that folks are competent to provide assistance in EMS calls. As the pandemic has expanded, we've learned a lot about local systems needing to adapt to what they have always done to a response that might be different. And then it includes everything from the PPE that we all are very familiar with, to alternate locations for transport. We've had EMS personnel that have been drawn into the COVID testing sites, folks that we get a lot of questions about whether they might be able to assist with vaccinations and immunizations going forward. whether EMS personnel can use ventilators, and those were all topics that we discussed during the last revision of the National EMS Scope of Practice Model, and that we will continue to discuss with the educators going forward to make sure that EMS personnel are most educated to provide these therapies. Next slide. What is most important, I think, for you to realize, the number. I'm happy to see a lot of folks participating in the webinar today, because once an individual has become nationally certified, it is important and critical for them to realize that they don't have an authority to practice until a state grants them a license to practice. We'll be talking a little bit more about those skills that folks might integrate into their systems. And actually, if you could just switch to the next slide, I'd like to kind of talk about those things simultaneously. So as the pandemic has waved maybe multiple times across the nation, EMS folks have found themselves needing to be more informed about the use of ventilators. In the last Scope of Practice Model revision, we had a specific conversation about that, because there was really not a specific standard related to mechanical ventilators, and especially those that are being used in the field. And so the expert panel actually took a step back in that regard and decided that what was really important was for the medical directors to become involved in whether an EMS agency allows the use of ventilators by EMS personnel and at what level. Many years ago, EMTs were authorized in some states to use ventilators for stable patients being transferred to rehab units. And so the quick answer to all those questions is, can EMS personnel participate in vaccinations related to COVID? Can EMS personnel use ventilators in their communities related to COVID patients? And all those things are really visualized best by the graphic that is on the screen right now. An EMS medical director working with the state has decided that a particular region has a need to implement those things. Those are things that are going on in the background to what you might be aware of in regards to a pandemic response. So the answer to the question is seen in the center there. An individual may perform procedures for which they're educated, certified, licensed, and credentialed. Has the pandemic had an effect on the state EMS office? Well, without a doubt, it has had an impact on every aspect of all of our lives. Many of the state education coordinators are getting drawn into contact tracing and other functions within the health departments. Folks are really just trying to adapt as the day-to-day needs become realized. And so the last slide. Just keep in mind that as you're making a determination from one day to the next, that it is all these interfaces on an EMS personnel being educated in regards to a particular skill, that they have the background and knowledge and experience to be able to perform them. They have been exposed to some sort of testing mechanism, and the initial licensure in all states is based on the National Registry of EMTs at all levels, that they have a state license to practice, and that their medical director in an oversight authority has provided them permission to do so. And so I think that's probably where I'd like to leave it, Dr. Kramer, and I'm happy to answer any questions going forward.
Thank you, Kathy. I'd like to turn for a second to two of our guest panelists today. George, thoughts, perspectives from the OAMSP?
Thanks, John. Yeah, sure. I think, everything that Bill and Kathy have talked about are things that we're seeing at the paramedic level. And the biggest I think the biggest challenge, well, there's multiple challenges, but one of the biggest challenges is students having an opportunity to get back into a laboratory setting or complete clinicals or even field internship capstone experiences. Many of the educators around the country, I think, have found a way to flip their classrooms. If you hadn't flipped your classroom before, you're flipping it now. You're typically front-loading most of your education and then finding an opportunity, depending on your local community, your administration, really at your particular schoolhouse, whether they're open to allowing students to be back into the building. And again, I think, John, this is just something that's going to kind of creep forward and probably lurch backwards a little bit for a while. I don't know that anybody has a handle on this, but I would say at the end of the day, paramedics are sort of at the end of the pipeline. The folks that are at the beginning of the pipeline in the EMT court, or the EMRs, EMTs, AEMTs, those students are not able to progress through that pipeline. We're going to be in a difficult spot, as Bill articulated, down the road. So that's kind of where we're at the moment. But we've got 700 plus paramedic programs that are going on in the United States right now, and all of them are working hard to try to keep paramedics in the pipeline.
Thank you, George. Yeah, we'll circle back in a couple of minutes to the first responder and basic training as well. Jay, thoughts from CAPC's perspective?
Good morning. It's always difficult when, these times of crisis, when you're relying on EMS providers to do more and sometimes with less. Some people would like to have EMS providers swap COVID testing or get updated on vent settings and how to manage a ventilator and keep the correct settings when you're transferring a patient from one facility to another, for standard of care. But those things require training. And because of COVID, it's very, very difficult to maintain training levels that we have, let alone add new things. So we're encouraging all of our accredited providers to be innovative, to do as much online, face-to-face, instructor-led training as you possibly can to keep people up to speed. And I agree with Dr. Hatch, getting students back into the classroom, getting them to do skills labs in a format where we can keep them socially distant and to maintain PPE and safety for all those people, and maintaining safety of the general population is a difficult task. And every time there's a time of crisis, EMS providers are required to do more. But I think innovation is the key. Relaxation of standards in some cases is the key. Keeping people engaged and safe is extremely important. So the more we can do to keep our EMS providers tested, safe, healthy, but trained and up to speed is imperative.
Thank you, Jay. Rick?
Yeah, I want to actually comment on Jay's use of the word innovation, which he used a few times. I actually think that's like absolutely critical. We're not in the same place we were. It's just like worst disaster in a century. So innovation is extraordinarily critical, like huge paradigm shifts, huge changes that we can't just go gravitate to it's awful and we can't do this. It's the innovation piece that I think is really critical. And in particular, I think a lot about skills and training and assessment. We have a long history in medicine, and I include EMS with that medicine, of these are the things that we do skills training on. We also have a long history in medicine of seeing patients face to face, but medicine's flipped around quite a bit in doing telemedicine. How is it that we can adapt very quickly to figure out which skills actually can be taught and achieve the competencies you really want to achieve for some skills that traditionally were sort of etched in stone? We have to do this hands-on. And I'm not clear about which ones would lend themselves to doing remote learning skills and figuring out the competencies, but there are a lot of smart educators in EMS that ought to be able to work on figuring that out. and not figuring it out like as a research project, but like what works right now. Anyway, over.
Thanks, Ray. That leads very nicely into a follow-up question that I'll get to in a second. But from any of the other panelists, any initial thoughts for Carol? Go ahead.
I'm a medical director of an EMS program, and we're struggling because simulation is great, but we are a patient care field, and it's not just limited to EMS, it's medicine and nursing. And I had a conversation with Rick Serino, and I was laughing. I said, as a patient, I'm not sure if I'm really comfortable being treated by somebody who's essentially done all their procedures on what equivalent to a plastic doll. And it's great to get the skill down and to protect the patient, but you also lose that element of, calming somebody down if they're afraid of getting an IV and things like that. So I'm curious to see what the research will show in the future about, what's the correct balance between using simulation and then actually having, a real patient there. And maybe we'll have to come up with folks. I remember in medical school, we had volunteer patients that we would practice certain procedures on that, they could screen and make sure that they're COVID free as long as they don't mind, several needle pokes.
Thanks, Carol. I think I'd like to go to the polling questions real quickly because that will prompt a couple of the follow-up things that we have talked about. Bruce, can you pull those up or Patrick? Okay. Today, which one of the following best characterizes your EMS system and COVID-19 response? You will see some of the questions that we had this morning have been used in previous sessions, and part of that is to allow us to follow things from a time perspective. We have a close race between preparing for a surge and responding to a surge. We'll let it go for another 10 seconds or so. Okay. Very good. Responding to the surge, but a fair amount of folks are still in the process of preparing. I won't ask how many of those are in the Midwest or upper Midwest. Next question. Your EMS system, and this question applies or includes any that you're currently working on. In addition to COVID-19 activities, which of the following have you begun additional preparations for? Seasonal influenza, hurricane, particularly folks on the East Coast, wildfire, tornado, earthquake, heat wave, protest, or others? For another few seconds here. Okay. Seasonal influenza, wildfire, even more so than hurricane response, and certainly heat wave. Thank you. Next question, please. Since the onset of the COVID-19 event, what is your perspective of the level of interest in a career in EMS in those looking for a meaningful career? So of those folks looking forward to their career, are folks increasingly thinking about EMS the same or decreasing? We'll go for another 10 seconds or so. We're almost at 50%. Come on, folks. There we go. Great, thanks. Bruce? The same or decreasing? All right. Next question, please, because that follows on this current question. From your perspective, is the possibility of contracting COVID-19 preventing some potential students from entering EMS as a career? Yes, no, unsure. Folks are picking up on this one. We're easily over 50%. Okay, Bruce. COVID is affecting the consideration that some folks are making. All right, thank you. Next question, please. Currently, as it relates to getting EMS students through the education pipeline, which of the following are major impediments? Didactic education, clinical education, capstone opportunities, field internship, national certification. This one's going up very quickly too. We'll let it go for another 10 seconds or so. Okay. Clinical education and field internship opportunities. Thank you. We're going to circle back on that one as well. Next question, please. Of the educational programs with which you are familiar, which of the following aspects is currently the most difficult to complete? Same options. Some folks in the chat are wondering about distinguishing between initial and continuing education as well. Okay, I think we've maxed out on this one. Similar responses here, clinical education and field internship. Thank you. Next question. Has the ability to obtain continuing education impacted your staff's ability to maintain certification or licensure? Yes, no, or unsure. This one's going up nicely as well. Another few seconds. Okay. Bruce? No, 50%. Yes, 37%. Very good. Thank you. Next question. This also is a repeat from previously. Improving your EMS agency's working relationship with which one of the following would make you much more prepared for an additional surge of COVID-19? Emergency departments, public health, emergency management, supply distribution change, behavioral health resources, other EMS agencies. Just for folks' awareness, I have the ability to look at the percentage of responses that are coming in. So we'll wait for another couple of seconds since this is multiple choice. Okay, Bruce. public health, and supply chain distribution. One of the things that I'll ask the audience to respond in the chat box or the panelists to participate in, has obtaining PPE for educational purposes been difficult for the programs? And I think that's our last question, Bruce. Do we have another question, Bruce, or is that the last one?
John, Amanda's moving those. I think
I'm sorry.
that's okay.
Yep, we're good. All right. Thank you, folks. All right, circling back to the panel in general, and actually, before we proceed, we had two other panelists join us. Crystal, if you can very quickly introduce yourself, welcome.
Hi, thank you. Crystal Lawrence with APCO International, the Communications Center and 911 Services Manager.
Thank you. Thanks for joining us. Greg? Greg Scott? All right, we'll go on. So Dan, go ahead, please.
I just wanted to jump in 2 points that I wanted to touch on based on what George and a couple other people said. And one is that, you know, it's kind of funny in high volume systems, you know, it's easier for people to acquire competency. And in a lot of the communities that we've seen these massive outbreaks of COVID where the EMS systems have become overwhelmed, we've actually built a class of clinical providers who've gotten an incredible amount of experience with assessment and treatment. Our biggest challenge, and competency and competence are two different things, right? So competence means that, you know, if you're competent, you know, you're safe to enter the profession. Competency is that trajectory from apprentice all the way to master clinician. And I think that this is an incredible opportunity for us now as educators, that we should sort of leverage these incredibly highly competent clinicians and use them as clinical mentors for people that are coming out, that are doing a lot of, they might be doing some high fidelity sim, they may not have the clinical experience. And so this is an incredible opportunity to kind of build that class that we need. And, you know, it fosters a transfer of knowledge, right? Because when guys kind of time out and they retire, where does that knowledge go? They take it with them, you know. But now, if we have these clinical mentors, they can continue to pass that knowledge down, and vice, you know, and back and back and back. So, you know, we never really lose that. And then the other thing too is that, you know, the biggest hit we're always going to take is pay and benefits. And I think that COVID has probably highlighted a lot of that for us right now to attract people to the profession. You know, they see a lot of risk. They hear about providers that die. They hear about providers that are so sick, they might not be able to come back to the profession. And what do I have to show for it at the end of the day in regards to a benefit package, retirement? Are they going to take care of me? And these are things we have to address them. We have to address them. We can't turn a blind eye moving forward.
Thanks, Dan. Bill, we had a specific question that I'll bounce back to you. Is there any thought of extending the recertification process to 3 years instead of 2? And would that help in recruitment and retention?
So our recently we had the extension from March 31st through June 30th due to COVID. But the standing, for lack of a better term, tradition of 2-year cycle is in align with with certainly not the traditions and customs of EMS, but with other certification organizations. And it also is, there's really no evidence to say that expansion of it or contraction of it would be ideal. Furthermore, the states that largely require national registry as a prerequisite have more aligned their certifications with 2 years, more so than 3 or 4 or more years than that. So based on the model and from a systematic perspective, 2 years seems to be more appropriate. And also, unless we have really any evidence to support it as being advantageous, we'd rather stick with that as it aligns with the needs, most needs of the states that require state certification for state licensure.
Kathy, this one is not intended to pick on you. You just happen to be in that particular seat on this panel. How are states squaring the needs of local communities and medical director discretion in cases where the scope of practice is enshrined in statute?
Well, that's a great question. And actually, I wanted to tag on a little bit to what Bill said. You know, it is really incumbent upon all partners to participate in the solution, from individuals to agencies and managers and everybody that's involved, to make sure that we have competent practitioners going forward. So I really appreciate what Dan had to say about that. And we've certainly heard a lot of different scenarios where there's really been no suffrage as far as the quality of education and skills, and the and one agency had EMTs on the streets that had never touched a patient to take a blood pressure. So the question that I hear pretty frequently that's related to the one that you just asked me, John, is really about, if we can make these exceptions now, why can't we have them in place all the time? And maybe the burdens that people perceive to be issues among EMS practitioners or potential candidates would go away. And I don't think that any of us think that the answer is to lower the bar. It's really incumbent upon the EMS medical director, and I'm looking at Dr. Cunningham on my screen right now because she's been a great resource to us at NASEMSO in helping to understand some of the challenges that medical directors are facing. Many of the folks on the panel today, and I know several folks that are participating as attendees, are familiar with my background in nursing, and I can tell you that most hospital emergency department have a day every single year, if not twice a year, where they make sure that their all personnel run through the tasks that they're asked to perform on a regular basis. So I don't think that it's fair to look at the states. I don't think it's fair to look at just the medical directors. I think certainly those are the ones that have the authority to have a great impact on practice. But we also need to ask our EMS agencies to make sure that their personnel have the resources that they need to learn. You know, Jay alluded to the fact that there's ample educational opportunities available. I just can't overstate the need for us all to continue to work together to make sure that our communities have those solutions. And as far as states are concerned in that regard, they're working with their communities and the needs that those communities have. If in my home state of Pennsylvania, we have ample ALS services in our metropolitan areas for their services to be provided there. In the more rural areas, those are some of the things that we need to probably take a look at. But I really think that it's important that we're all continuing to have these discussions and recognizing all of us have a role in making this better and sustainable.
Thanks, Kathy. Garth?
Yeah, I would like to echo that. I think that as EMS physicians, what we really need to do is collaborate with our county, state committees that are in charge of the statutes and rules that govern EMS care within our our states, counties, and municipalities. I think the drumbeat should be that statutes and rules handicap us and keep us from being innovative. Other things that are less prescriptive, like substantive policy statements, guidance documents, still allow the state to keep the bar high, but allow for the medical director to introduce innovation into the system. So I think those might be keywords we can use when approaching our governorships and our councils and so on.
Thank you, Garth. We have a couple minutes remaining. I'm going to open this up to all of the panelists and ask you in 15 to 20 seconds or less, either indicate what you think the biggest education issue we have to address in the next 6 months is, or what will EMS education look like in 5 years? Carol?
For me, we've shifted over to simulation so quickly, yet our rural and volunteer EMS agencies have a challenge buying one simulator, and we cannot leave those communities behind. Thank you.
Thank you, Carol. Dan?
The interdependent partnerships that make education successful, so that hospital time, the internship out in the field, bringing all of those things together and getting everybody on the same page, that's one of the biggest issues that we're facing currently.
Dave Gerstner? You're on mute, Dave.
Sorry. Couple of things. First of all, the long-term issues revolve around clinical education and trying to figure out ways to get that done. We have EMS agencies that don't want to let people in, and we have hospitals that don't want to let people in. In the shorter term, we've got to look at education for the changing environment, doing new things such as vaccinations and testing.
Rob?
Yeah, I could definitely, well, first let me thank Kathy and Bill for their presentations. They were good. I always enjoy their presentations. But I think I agree with Dave and even Dr. Cunningham. Clinical rounds are going to be probably our biggest obstacle in the near future. Trying to overcome that, and the cost of simulation is going to be a barrier for a lot of people. So,
thanks, Rob. Alex?
I think one, since we're trying to do so much in simulation and trying to keep our learners safe, work with local infection prevention resources, some SME, to make sure we're setting those labs up as safely as possible. And then two, we know the importance of clinical rotations and access, even more difficult now in COVID. Supply chain and PPE for our learners is one of those barriers. So that's an issue that we should try and tackle as well.
Thanks, Alex. Craig?
So I'm reminded of a meme that showed nurses caring for COVID patients in February with hazmat suits on, and then in June they were in t-shirts and shorts caring for patients. So, and I think that illustrates our comfort level as we begin to increase our knowledge and awareness and know what some of the countermeasures are. Our greatest challenge in the short term is that clinical piece. In the military, we call it prepping the battlefield. We need to go in and talk with the folks, educate our partners, recognize that we can provide PPE for our students, engage in the conversations that they'll be in working in these kind of environments, and don't expect no for the first 1 or 2 tries, but after that, and be persistent, address the concerns that are raised. But I think increasing comfort level of our partners is key, and making them aware that we understand the concerns. We want to support those, but we do need to get our students with actual patient care. And I think there are some strategies that we can do to enhance that, but it will take some time and hard work on behalf of our educators. Thank you.
Thank you. Kathy and Bill, thank you for joining us today. Any final thoughts?
The only thing I would say is, well, thank you for having certainly me and us. And I think the solutions are, as we like to say, it's a systems approach. It's not going to be us or you or them. It's going to be collectively all of us. And we need not forget that, especially in these unprecedented times.
Well, that's absolutely for sure. We're all in this together, and I don't think that wringing our hands or throwing our hands up in the air and saying that we can't overcome this is really the solution. That it's flexibility, as many people have talked about today, and cooperation. That's really what's going to get us through this. I think the thing that we need the most is to, I just want to go back to the science, understanding a lot about the spread and the treatments that we don't know now. And obviously those aren't at hand for us at this moment, but we do need to continue to monitor them and expect everyone to follow the science and the medicine that and helps us all ensure proper care. And thanks for the opportunity. I really appreciate it, as does NASEMSO.
Thank you very much. George and Jay, also thank you for joining us. The rest of the panelists, thank you. Bruce, Amanda, Amy, thank you. And thank you to everybody who joined us today. Again, we'll have another EMS session next Monday, noon Eastern time. Critical care, clinical rounds tomorrow at noon, and emergency department clinical rounds Thursday at noon. Thank you all for joining us. Have a great week.